All right, so here we are. All right. So again, this is about patient-centered care and community integration. I am going to try to make it as interactive as possible since it's only us. And a lot of people, like there were a couple of emails that asked for the recording, so we'll send this to them and ask, ask for any feedback that they might have as well. Liz, I did talk to Michael before you got in. One of the things that I'm going to ask everyone is to email me themes or subjects that you would want to see in our next round of family education, because this is actually our last installment of this round. So we'll probably, I would say, just to develop the material, we'll probably start sometime in August, but I would like to develop material that is relevant to you guys, like things that maybe we did go, over too soon or too fast, or things that we didn't touch and will be important to learn about. So just send me your suggestions, please. Okay, so patient-centered care and community integration. That is what continuum of care is all about. And that's why we wanted to present this model. There's been a lot of research about the difference in between a one-sided approach to clients' well-being and recovery and a multidisciplinary approach to clients' well-being and recovery. And I've been reading a lot about sort of like decolonization theory, and I can go on and on about it. But basically, the bottom line of or what decolonization means is to do treatment and to do counseling and mental health treatment from the perspective of the client. Like a lot of approaches in many sciences have been from the approach of the researcher or from the approach of the treater, and it's been a vertical approach to the people that is in the receiving end, and has had not great. I mean, you guys probably have experienced some of this, right? Like not great results, because if there's no buy-in from the client, there's not much progress that one can make. So community integration and patient-centered approach comes from again, decolonizing view in which there's no top-down approach from the I am the treater, you're the client, but it's more like you are the client, you tell us what you need. So okay, we're going to start a little bit of the conversation here, but this is sort of the same thing that I'm talking about. Recovery is unique. Everyone has a different road. Treatment options vary. And the most important thing is that a lot of treatment is available for clients. In like individuals, especially with psychosis, but I would add with serious mental illness, do have a hard time sometimes doing things alone. They do need their families, they do need their community. They need a combination of different approaches to ultimately be successful. So I'm going to put you both on the spot and ask you, in your journey with your family member, what do you think has been, two questions, what do you think has been the sort of most effective approach, and what are the approaches that have just not worked?
Yeah, so I'll go.
Okay.
So, I appreciate you talking about, sort of being client-centered and, one-size-fits-all therapy is, not the right approach. And, I've seen with, Jessie, our daughter, she is more responsive to more customized treatment, and cookie cutter approach doesn't always work for her. She doesn't buy in to everything. And, you know, when you recognize that, you know, in some cases she's not buying in, using a more tailored approach seems to work better. And, you know, I appreciate that you are creative with some of your therapies and, you know, trying to find, you know, what works, because, you know, everybody is different and the same things don't work for everyone. So we appreciate that you have that flexibility.
Thank you. Thank you. Yeah, I know that Jesse's journey has been long, and you're right. Like, even when she's had the opportunity to find some treatments that are geared to, you know, specific aspects of her condition, they have not worked for the most part because they were pretty cookie cutter, and she, you know, she doesn't do well with that.
Right.
Liz, what has been your experience? You're muted.
I really don't have anything to say in this public. Michael, you're the only one there, but I don't really have anything to say.
Mm-hmm. Mm-hmm.
I don't. I think that I don't understand, you know, what he was saying about cookie cutter or the I mean, he seems more hands-on than I am, I guess. I don't really know that there has been one sort of thing happening and a better one is happening because of it. I just don't know that.
Mm-hmm. Mm-hmm. I think it has to do a little bit with the agency of the client, right? In the case of Michael's daughter, when she has no agency, when the program is imposed on her, it doesn't go well for her. When somebody tells her what to do, basically, and she has no option to make choices, it doesn't go well for her.
Choices.
Yeah, and I think that's a common experience among young people, about young adults especially, right? They want to be able to say what they think about treatment. They want to be able to have an opinion. They want to be at the table when treatment is happening. And if that's not allowed or not available in certain settings, you know, it just, treatment doesn't work, not because it's not good treatment, but because they haven't been called to the table. All right. Coordinated specialty care.
Oh,
so go ahead. Go ahead.
I don't have the screen showing the right way. One sec. Okay, thanks. Sorry.
Okay. All right. Coordinated specialty care. So number of research has shown in the different settings has shown that when there is a coordinated care, and that includes a bunch of things being offered, overall clients with serious mental illness tend to do better. They have higher global functioning. That means they do better in general in terms of what they can do in the community. They, you know, and global functioning is an old construct that used to be part of how you diagnose in the DSM-3 and 4. DSM-5 doesn't use it anymore, but it basically indicated how well can you be independent, how well can you take care of yourself, how well can you advocate for yourself. So basically, an integrated approach will ensure that in general, clients with serious mental illness will achieve a higher global functioning. And in part, it's kind of obvious to a certain extent, because, you know, if you have more agency on your treatment, you learn to have agency in your life. You are still on the driver's seat. They're more likely to be employed or in a school, again, because they have agency. They have the functioning is better. They have a better quality of life, and they have lower risk for relapse. And I would argue that they have lower risk for abandoning treatment, which will correlate with relapse, right? If treatment responds to my needs, if treatment it's treatment for me, not treatment for everyone that comes into this place, the chances of them abandoning treatment or stopping their medications or stopping going to therapy or doing the things that people do when they're not happy with treatment will be less. Coordinated specialty care does not prioritize any treatment or any treatment approach. So, if you sometimes in the more like prescribed approaches, there'll be some kind of treatment modality that is emphasized, right? If you go to that's the Compass font. If you go to a treatment facility that does interventional psychiatry, ECT, ketamine, or TMS, chances are that will be the treatment. That will be what will be emphasized, right? Whereas the other components of treatment might be minimal or not provided at all. If you go to a particular program that has a very prescribed therapeutic approach, a DBT program, for example, then that's what you're doing. You're doing DBT, and the other aspects of treatment, again, might be there minimally or not at all. So what we try again to do a continuum is to offer all these components of treatment with no particular priority. We don't necessarily emphasize medication management over case management. They're equally important. Individual therapy over group therapy, equally important. Supportive employment and education, equally important part of our treatment. Peer support services, both in terms of getting our clients to have peer supports, having peers among the staff that can sort of role model for them, but also having the opportunity to eventually become a peer if they are well and in recovery. And of course, a component of family education that we're doing right now. Because again, sometimes, especially with a young adult, families don't have much empowerment because they're not anymore in charge of their kid. The kid's an adult. But having information and knowing right strategies to approach what's going on empowers you. So that's what we're trying to do with this. And again, Michael, you were mentioning that the creativity for treatment is important. The creativity comes from this, right? If something gets to a sort of a stop, a roadblock, medication gets to a roadblock. This is the best we can get with medication. Well, let's try this other thing from other angle of treatment that might still improve overall functioning. If the patient is not engaging in therapy, maybe we've come to a roadblock. Maybe we increase the number of activities in the community for behavioral activation and to, maybe try to find supportive employment, peer supports, things that the person can do that are not called quote unquote therapy. So there's different approaches that makes that enriches the experience of your family member. Any concerns, comments? You're unmuted, Liz, if you want to say something.
No. Oh, no, I am. I'm not muted.
That's okay, because it's just the three of us. You can stay unmuted. It's good.
I'm not muted.
Yeah, no, that's good. All right. Other recommended treatment programs, and this is just general things that we use, but also are like evidence-based treatment, which again might change as the field evolves, but at the present moment, this is what's working and what we're trying to use in our program. So this is what we use a lot, cognitive behavioral therapy for psychosis. And we use cognitive behavioral therapy in general. A number of our clinicians in CRM.
I thought you said you didn't.
We do CBT.
Okay. Good.
We are not a DBT program. So DBT, we have
not DBT, but you're CBT.
Yes. So DBT, we have a couple of clinicians that are DBT trained. So if it's needed, we can use it for a particular client. I can tell you that of all our clinicians, including myself, we're probably all of us CBT trained. So it's really, sort of our main modality of treatment.
Do you know when I was asking one of John's former doctors, excuse me for interrupting, if he did DBT or CBT, he said, no, just BT, just behavior therapy. And okay, but I mean, I don't know what to, but whatever it is, I'm sorry to interrupt, but I will not mute myself. I'll just try to mute myself.
So no, behavioral therapy is a valid approach, and very useful, especially on a residential setting. That basically means that you basically reinforce the behavior or extend the behavior in a very, very traditional behavioral way. Like basically all my dogs do BT. I reinforce the behaviors that I want them to have, and I extend the behaviors that I don't want them to have. So that's behavioral therapy. That's, but there's not much cognition to it. Useful with children and dogs, and even with people that are not behaving the greatest, but not useful in the long run to gain insight into how to, know yourself and how to solve your problems for the future, which more cognitive approaches like CBT or DBT will help with. But in the immediate moment, if someone is, for example, trying to hurt themselves, a behavioral approach is excellent, right? Because you don't want that person to continue with that behavior, and you will not reinforce it at all. You will stop that behavior. So I guess it's valid that psychiatrists did behavioral therapy, but not very useful in the long run, but to manage behaviors in the here and now, useful.
But let me ask you one question. I am interrupting because I just didn't hear the word you said. When you say you encourage good behavior with your dog, that's probably a treat. And how did you say you discourage the other behavior?
You extend it. Basically, you do nothing about it. Extend it, like.
Oh, I don't know that word.
Yeah.
Okay.
So when you learn behavioral therapy, you learn that the best way to reinforce behavior, the best way to encourage someone to maintain a behavior, animal or human, is intermittent reinforcement. So yes, a treat, but not a treat all the time. If you give them a treat all the time, they become bored and they don't care about the treat.
Yeah. I mean, it could be with a dog, you could pat him on the head, you could be, lots of things. I don't know what you do for, I don't really know enough about behavior therapy. I really should have studied it along the way. Like, go ahead.
With a human, let's say they want attention, right? The best way to extend the desire for attention is to not give attention. If you give attention every once in a while, you're actually reinforcing their behavior and maintaining it. So with a human, it's very important to not reinforce intermittently the things that we don't want, right? With our children, especially, if they nag you, and you're like, don't hear it, and finally your ears are, buzzing and you cave, now you reinforce. It's, if you say you're not going to eat chocolate and you end up eating chocolate every once in a while, you're going to continue to eat chocolate throughout your life. It's because it's intermittently reinforced. So the best way to maintain a behavior is to intermittently reinforce it. So we sometimes intermittently reinforce behavior by accident. And that's I think the better lesson to learn with in relationships, right? Sometimes we end up reinforcing behavior that we don't want to see because we are not consistent on our own behavior when that behavior presents. Again, not long-term interventions, for people to gain insight and for people to learn skills and for people to be independent on the management on their own behavior. You probably need a more cognitive approach, and this is why CBT it's evidence-based in that sense, because it makes people independent. Like my dogs depend on me to reward them to do what they have to do. But they're dogs. We don't want people to depend on their environment to tell them what to do. We want people to independently be able to choose what they're doing, which is the cognitive part of the cognitive behavioral therapy. Because when you do cognitive behavioral therapy, you learn to, instead of people telling you that, don't do that, I'm not going to reinforce that, or with their actions not reinforcing your behavior, you're now learning what happens when I feel this way. Oh, when this happens, I feel this way and I do this thing. So maybe if I take this out, I won't feel this way and I won't do this thing. Makes you more independent. Yes.
Is John doing it on his own? I mean, I'm not reinforcing it, and you probably are, right? You're probably helping him with intermittent enforcement or intermittent
with that, and we're helping him with cognitive behavioral therapy. For example, we do definitely reinforce the fact that he is maintaining a job and going to work and getting independently there, and being successful that way. That is something to be reinforced. That's something to praise him for, to tell him that you can do this stuff, that you're proud that he's doing it. We certainly tell him, we always, just the fact that he comes back from work and we're like, how did you do today? Great, I'm glad that you're still there. Reinforcing the good behavior of waking up in the morning, getting to work, doing your work, and coming back. And again, we just talk about how he's not feeling the best now and he's still going to work. That behavior has been reinforced. It's still important for him to do that.
Yeah, he looks back and realizes he never had a job that lasted more than a certain period of time. And when I look back on mine, I can't think of one that I kept that I didn't have at his age for 4 years. Not more, but not less. Around his age.
He likes, I'm not sure how he feels about his job, but he likes the fact that he's working and he's keeping a job. So
he's extremely ambivalent. Like sometimes he's down about it in words, and sometimes he sees it as a career and he's working toward it, and he's going to be, he talks about going to school and then going back into this business. And I think once he goes to school, he could go into any business. But I mean, he sees it as a, sorry, Michael, I said I wasn't going to talk. Is Michael still there? Because I only have your picture, Rista. If I have all the pictures, I can't read this side of the screen.
All right. So that's but cognitive behavioral therapy helps him and Jesse and all our clients gain insight about what's going on, which is the cognitive addition to the behavioral therapy. So yes, the good behaviors, the things that they're doing well, are reinforced, and obviously you can reinforce them as well. But it's not enough to just reinforce the behavior externally, right? They need to learn how to reinforce their own behavior. They need to learn the value of their behavior. So what John is doing by starting to think about his job and thinking that it's a valuable thing, that he's doing well, that he wants to go to school and go in the business, those are all things his own internal reinforces. We are not telling him to think that way. He is reinforcing his employment behavior in a way that is positive for him.
So I'm gonna be a little better in case we have a family meeting, because this is all making me want to say stuff that I don't really need to hear.
Okay, Liz, here I'm gonna send this. This is actually a CBT website that has CBT training for families. It's really cool. If you want to learn a little bit more about how to, have interactions that are CBT oriented with your family, I would suggest that you use this link. When I send you the slides, it is really didactic. It's not boring at all. It's like sort of like CBT for dummies kind of thing. So it's for the lay person, but it teaches families how to use CBT techniques with their family member.
And when you said it's didactic, that sounds like the word from DBT.
It's didactic, meaning it's a teaching tool. It's like what the teachers use in school.
Do I pay for it, Rista?
No, it's there. You can just, if you click there, you'll see it. It's really fun.
When you send it to me, right?
Yeah.
Because I have all of John's old notebooks and I think, oh, should I just read these? And I haven't.
No, try this one. It's really good.
Okay.
I tested it before I put it in there. All right. Supportive employment services. And again, I know you promised to not talk, but I would use John as an example. John went to a fellowship as part of finding his job. Fellowship is an example of supportive employment services. They do as much as the client needs or as little as the client needs, but the goal of fellowship or our apprenticeship program, for example, is to help people be employed if they want to. Again, it's one option, right? But fellowship helps with resume writing, with career exploration, with interview preparedness, with all the things that you need to become employed to the extent that you want to be employed. Because, I'll put the example more of our apprenticeship program, for example. We have a number of clients right now in both our Tyler SPAT and Davis SPAT programs that are doing our apprenticeship program. Some of them are not working full-time and they can't, not because they are unable, but because they need the regrouping time of working intermittent days, for example. So supportive employment might be just that. Instead of working full-time, I'm going to give you a day in between working days so that you can regroup, that you can do some self-care and then be effective at your work and enjoy it, right? Because you don't want someone that goes to work and is like, I hate this.
6 days a week's a lot, though, I think, Rista. I know his brother works at, we almost all did in salaried jobs, but I think it's a lot. And I thought he chose that job too quickly, but
I would tell you, John is not one of the people that needs a break in between. He enjoys going to work, and he will come in the morning and be like, I'm going to work, and he likes to take the bus.
All right.
It's not, but we have other clients that do need a break in between, and that's fine. That doesn't mean they're not being successful. That means that we are supporting them in what they need to eventually integrate themselves into the work environment. Some of our clients are not working at all, and they're volunteering. I mean, I think Jessie is in that situation. She really enjoys it when she volunteers. That's where she's at right now. That is what we're encouraging. That is also considered supportive employment services, because ultimately we are redefining employment not so much as a thing that you have to do, but a thing that will fulfill you and will be a rewarding experience for you. So as long as the experience is rewarding in any capacity, right? Soup kitchen, that's a favorite for many of ours. Sometimes they go on, just move things around. There's a local school that just move things around. Some of them have done reading programs and tutoring programs, and if they like it, they can do it. And then we have the apprenticeship program and continuum, which has very manual labor, or some of our clients are like doing the reception desk at our office, and like whatever works for them to make work a healing experience. All right, assertive community treatment. This is a model used by many actually state departments. I used to work in New Jersey, and they have a whole ACT team for the management of clients with serious mental illness. Most of the continuum programs do mimic the model because it basically brings services home. In other words, when you have an ACT team or an ACT team, the model goes from like most clients with mental illness, the model is like you make an appointment with your psychiatrist, you make an appointment with your therapist, you go to an IOP, you go to treatment instead of treatment coming to you. With an ACT team, treatment comes to you. So if you think David's path or even Julian's path, case managers come to you. Your therapist or your psychiatrist comes to you. Your services are available for you in your own terms. And again, like Michael was saying, traditional services don't work for people sometimes. So the fact that people can be creative and do therapy walking, right? A lot of our clients like to go for walks as they have their therapy session. Do case management as you go food shopping, and you start talking about things and learning the skills. Or recently we just had a family meeting today with someone that needs summer clothes, and the whole case management activity is going to become like a girl's day going to shop for new clothes. But in the process of doing that with this person, you learn the skills that you need to do that independently in the future. Or you practice, if you had them before, you practice the skills that you need to do that independently in the future. So the ACT model or the ACT model basically means being creative, bringing treatment to clients instead of just doing treatment in the traditional office settings. And sometimes treatment is done in the community, in the client's home, in the client's residence, at work, wherever they need the support. And there is some links in here too, so you can learn a little bit more about evidence-based practices. But it's again our model, especially in our step-down programs. Except for Luna's path, most of our clients do experience treatment coming to them. Peer supports. I've recently been going to like a number of conferences actually, and this is one of the things that is encouraged from most providers. There is a bunch of research that has already come out and research that is being developed in terms of peer supports. Two sides to this. One, having people that has lived experience as part of the treatment team encourages people, provides a role model, makes people, our clients, see that it's possible to be better, right? If this person is here treating me, but at some point this person was a client, I can do the same. It's honestly a career path for some of our clients as well. Part of our, or a separate sort of branch of our apprenticeship program is to have a peer support training sort of branch. Clients that decide to become peers after a period of recovery can do that and eventually find employment as peers, as trained peers.
I think of John as doing something like that or writing a book about it. Although I do see that sometimes writers, not just smoke, but drink. Mm-hmm. And so, I would think it would be hard to go back to some of those things that he could do well, which was right, but that got way out of hand. But maybe he won't do that kind of thing, but it might be something he would do to relate what happened to him.
Yeah, I think if it's something that he decides he wants to do,
right,
it will be something that he can do, right?
It would happen organically if he wanted to do it.
Exactly. But it's an option, and it's an option for all our clients as well. Definitely doing, joining peer support. And, we have some clients that are not yet ready to do peer support, but for example, decide to run some groups themselves, right? And that's a way to start experiencing the field of doing peer support. some of them, co-lead certain things, walks or groups or activities. That's a way to start finding out if peer support is for me. And here are other useful interventions, skill training programs. We have a lot of that going on, especially at Luna's Path and Davis Path. This is where we use a lot of our DBT training. Distress tolerance is a DBT skill. Interpersonal effectiveness is a DBT skill. Problem solving is more of a CBT technique. But a lot of the skill training that we do in our higher levels of care is our therapeutic interventions that come from these evidence-based models. One of the things that I think Holly and I are talking about doing at CRS especially is doing also more basic skill training. We're trying to be creative, like Michael said, with our programming. But some of the things that our clinical coordinators can do and like to do sometimes is teaching more basic skills, right? Like, I don't know, vegetarian cooking, if we have a lot of vegetarian clients, or any kind of housekeeping activities, some sort of like how to room organizing, things that are very practical for independent living, right?
I do think cooking is very important, and
yeah.
and it's too bad that like if he's not a vegetarian, it might not work for people that are even in the kitchen or room or sitting down. Meat is sort of a smelly. But I mean, I think cooking is essential, because I love to cook for my son, but he seems to just long for all those corner stores, that Popeye and Taco, and because it's so darn tasty. But I think he should think about his physical health as much as his mental health, not just processed, highly processed.
I think that part, like, it's also not unique to him. I think that one of the things that a lot of our clients struggle with is, having the time and having the organizational skills to cook for themselves. It's really sometimes, it's stressful. So we try right now at Davis Path, we do have a cooking group regularly, but we're definitely talking about making this a more consistent thing. It is definitely a skill that we want to promote among our clients and make it something fun and something accessible. If anything, because a lot of our clients, of course, will prefer to call, Uber Eats than to actually
yes
and cook.
Well, sometimes that's not all bad for them, I guess, Uber Eats, but the ones that I can see, Silver Hill did a lot of cooking. I know that was, people think it was a country club, but because of the bucolic setting, but they cooked for them and they could cook with them. And I don't think John, I have two boys, I don't think he was ready to do it, but at least he got really wholesome meals, and better than he can make for himself.
Yeah.
Rista, he's trying to lose weight. It's a mistake.
Yeah.
He's thin.
I'm gonna let Fran talk because she has her very polite hand raised.
Oh, there's another person there. I'm so sorry.
I'm sorry, I joined a little bit late, but anyway, I just wanted to add to the comment too, even though my son is scheduled to be discharged tomorrow, but financial well-being is also an important aspect of being able to be independent and manage on the resources that they have available to them. And it's one thing with my son that I wish I didn't have to control so carefully, like if he has, whether he has $50 in his available to spend or $150 available to spend, it's spent. So, I haven't been able to impress upon him how to budget, how to manage his money. I found that to be very frustrating part of the equation. So now it's down to, well, I give him a limited amount of money to spend per week. And, whether he spends it on cigarettes, which is a big no-no, like it kills me that I giving him this money and he might be using it for cigarettes, or whether he spends it on his hobbies or, things that he buys online. It's gone like before the next week rolls around. And, I don't know, Rista, if you have any specific takeaways that I can try to,
One of the things that we do, it's budgeting group. I wish we could do it more. I also find that budgeting works at the individual level more than in the group sometimes. Yes. The most effective way that I've seen it work with our clients is in the food shopping trips or in the shopping trips. I don't know if you joined before or after I was talking, but we recently had a family meeting with another family, and we talked about how this person needs summer clothes.
Yes, I heard. Thank you.
Yeah. So the girls' trip to the for summer clothes, it's also a budgeting lesson, right? Like the case manager is going to go with this person and plan how much they're going to spend, figure out what kind of pieces of clothing this person needs to, size up and make sure that he has, in this case, things for work as well as to be in the house. So it becomes a whole teaching experience about how to budget and how to be effective with the money you have. But those are the sort of individual interventions that we were talking at the beginning of this conversation that might be unique for a particular person. So again, I don't know if your son will have the same opportunity of having case management in the place that he will be at, but that might be something that he'll need. Yes. Right? He'll need a one-to-one with a case manager that can help him do that.
Right. Yeah. I mean, fortunately for me, I guess, and for him, he is very low maintenance in terms of, what he doesn't aspire material things. So, but he likes to play video games. He plays with these Warhammer figurines. He's got his little pockets of interest and what he spends money on, but it's not like, I wish that I had a key to dangle and say, well, if you were able to save or put this much money away, maybe I would contribute or whatever, so that he has a goal in mind. It's never been like that. And, it's just like, it's basically, I feel like he's a, middle school kid that needs his pocket money.
Yeah, and I think that's a very common skill training function for case managers, to be able to work with them. I would say mostly individually, but definitely a budgeting group helps too.
Yeah.
You had a question? I'm sorry, Fran.
Sorry. No, I was just going to say, sorry, and then my last comment. As you know, it's not his first rodeo, and he's had case managers before, but there's nothing that and I'm the daughter of a bookkeeper, so my mother was like instilled this kind of thing on us from a very young age, and it really gave me the scaffolding to build on for my own personal financial management. But he's never been able to grasp that with all the input that he's had. I don't know what the solution is. Maybe it's just that I'll be giving him allowance for the rest of his life. It's not my goal, but it's not the worst thing.
Yeah. No, and it also depends on the approach. I think sometimes, and we were talking a little bit about this too, case management needs to be more targeted for skill training than just
Yes.
you know, sort of like accompanying through the journey, which is sometimes what a lot of case managers do. And also it depends. I mean, I know that a lot of the programs that sometimes are around are more contained programs. So case management is different when it's contained, because you don't really go shopping that much. You don't really go to the grocery store. You don't really
Yes, it's
do
done
those
for
things.
you. Mhm.
Whereas
It is.
when you have an in the community program like ours, you gotta go to the grocery store, you gotta go pick up your meds, you gotta, you know, do things. So in case management and skill training for those in the community skills becomes more
Mhm.
of a thing.
Understand.
Yeah. Liz.
Well, no, I wasn't, I'm sure this is not what you're saying, but would you ever consider having a, like a charge account at the closest grocery store so that that's where most of his money goes, if that's what you wanted? I know you want him to save for the goal, which you could
No,
just
I
say.
just want him to manage on the, you know, to live within his means, you know,
Yeah,
and not ask me on Monday after I've given him his allowance on Friday or Saturday that he needs more money to get through the week.
yeah,
Yeah.
yeah. Well, people always got paid on Friday. And in Angela's Ashes, they all drank it on the weekend. So Friday's not the best paid.
Well, he's not doing that.
No, but I
No.
mean, Friday's a weird day for.
Yeah,
pay.
Friday's a weird day. Yeah.
It can be.
All right. So then there is psychoeducation, which is in part what we're doing in this session with you guys, but there's also a lot of psychoeducation for our clients. Because again, psychoeducation is very empowering, right? One of the things that I like to do as part of the groups that I run, I wish I would run more, recently I haven't, but for example, psychoeducation about the effect of medications. That is eye-opening for clients. They understand why medications exist and work, and what's the limitation of medications as well, right? Because a lot of us, even us, have sometimes the misconception that, oh, I'm going to take an antidepressant and I'm not going to be depressed. And that's not necessarily true. I'm going to take an antidepressant and my neurotransmitters in my brain are going to be better to work on my depression, but there's another component that has to do with, you know, the cognitive work that you have to do to use those neurotransmitters. So, you know, it manages expectations. It teaches, you know, again, agency, right? I'm going to take a mood stabilizer and my mood will be stable and that's all I need to do. Well, it'll be better because you have better days and better, you know, control of your impulses. But again, there's work that you have to do at the behavioral level and at the cognitive level to actually effectively change your brain so that, you know, it can be optimized. So that's a group that I love to run. There's psychoeducation about, you know, how anxiety works, how trauma works, for example, for our clients that we do regularly. That opens their eyes about what's going on when they're having these episodes of severe dysregulation that they have no control over. You know, what is going on with my brain? How is my brain working different than when I'm not in this fight and flight kind of place? So if anything, empowers our clients to understand their illness and to take a more active role in their recovery. And then there is structured follow-up and monitoring, and this is probably from what you've seen the most with case management, right? These are the case managers that are basically making sure that the client is okay, that they might do you know, urine drug screens to make sure that they're not using anything, that they check that they've taken their meds, that they, you know, they monitor and make sure that they're doing what they have to do, which is very effective case management. But I think there are different kinds of case management. So the one that we were talking before with the budgeting and the, you know, cooking and stuff like that, that's the skill training case management that also is needed for a more comprehensive therapeutic approach. But yes, a lot of our clients, because of, you know, their inconsistency in engagement with treatment for many reasons, right? Because they have ups and downs in their illness, because they were at some point not as motivated as they are now, because of, you know, treatment just not being not responding well to what they need or want for life, they need this sort of accountability, the structure and accountability that these structured case managers provide. But again, a one-sided approach is not usually the best approach for this kind of chronic mental illness. And family involvement. This is why you guys are here. It is hard to be involved in the treatment of our adult children because they're adults and sometimes they have their own mind. And sometimes they limit our access to the information we get. You guys are lucky that you are not in that case currently, but it's sometimes scary that not everything is under our control when our kids are sick. So it's really, really important to be involved. Even if it's hard, it's important to be involved because the more you're in the picture, the more you will be in the picture. Because it becomes part of you are part of the network of wellness, right? Your presence here, it's part of what they get used to as part of what their treatment looks like. So when you, again, as we talked at the beginning, when you're talking about integrated treatment, we are talking about every component of treatment being important and compensating when something else is not working. So if, for example, my relationship is not going well with my treater, I have my family to guide me into either finding another treater or support me so I can repair that relationship. So even if sometimes you feel like you're like not doing as much as you could, or like, you know, sort of isolated or like not as involved as you could, the fact that you're here, the fact that your family members are signing releases for you to be involved in treatment, the fact that you know, you are there when they need you, that you're visiting, that you're involved, is important for them, because at some point you might have to take more of the pie. And you know, and I'm sure you want to. So but yes, so sometimes medications are the important thing, but sometimes they're not. Sometimes therapy is the important thing, and sometimes it, you know, hits a roadblock. Sometimes you will become the part of treatment that is carrying treatment. So remember that even if right now you're not, it does not matter that much. At some point you will, as long as you are still part of that circle of components that your family member has. And there are plenty of resources here about family training. NAMI has a good family training course. Yeah, Navigate has a whole thing too. I'm gonna send these things out for you guys to check the links. Some of them are pretty dense, so if you don't like them and you just click on them and are like, I'm not reading this, that's fine. But there are plenty of resources for families. So, and yeah, the NAMI course is super good. And then here are all other resources that are more like casual and you might be more interested on. I'm again sending all this information. These are a couple of podcasts that you can explore. There's a documentary that is also really, really good. So I do recommend that that you explore these. I actually did do, I probably listen to all the episodes of Madness Radio on my trip to Portland and back. So it was pretty good. I did review a couple of others, but these were like pretty good. So I do encourage you to like look at this as a more educational tool that is less dense probably than the other tools that I provided in the prior slides. And I am done. So I don't know if you have any final questions.
Thing that you're sending me on CBT is not part of this, it's separate.
Yeah, the CBT is in a prior slide, and that's actually training for parents on CBT. These are more like podcasts and things that just to learn and hear from the mom. Like actually, both of these podcasts are, you hear both from professionals and with people with mental illness. So it's a very comprehensive view into the word of mental illness and the word of treatment, and very candid reports about how treatment works for them or not. So
You say mental illness, and
Mhm.
and I can hear it and I think it, but I once referred to, and you referred to these, everybody here as clients. I once referred to John as a patient, and he was startled that you might have said that. But mental illness, you say that, but also you're referring to them as clients.
Mhm. Yeah, I mean, I think it's more comfortable with me, and people that are more progressive might argue that I'm actually not using the right words, but it's, to me, it's better than saying patient or or using other word for mental illness. I really think that most of these conditions are an illness, and I think it's a disservice to people to tell them that it's not, because they're an illness, right? If someone says that you have diabetes, nobody's going to tell you, no, you don't have diabetes. You have diabetes. That's
Don't have
an
an
illness,
illness,
and
yeah.
it's respected.
I try to word the sentence so I can say mental health. I mean, it gets convoluted, but you can sometimes get around saying mental illness depending on who you're talking to.
Yeah, and mental health problems. Yeah, I mean, mental health conditions.
Not even problems. You got really, yeah.
I mean, but yeah, I just, again, I think that it's appropriate to sort of like say mental illness in the sense that this is an illness and should be respected as an illness, should be treated as an illness, and should be, sort of, people should be heard, and there
Well,
should be
that's why
advocacy for
that's
them.
why I want there to be really good food, because I do think that the physical part of the body, I mean, your brain is also part of the physical part of your body. You should just be in good shape.
And I
Take good care.
like the word client, and again, like some people even would say that client is not the right word. Some people call our clients consumers, or other words. But I say that our client because I am to their service, right? I am here to do what they request me to do. I am not here to, again, we were talking at the beginning about colonization of many things, to tell them from up down, from a vertical position, that I know how to fix you, because I actually don't. So I think that it's a lot more respectful.
Yes,
To
a client is a dignified way to address, I think so too. I prefer that than a patient. You think of an inpatient in a hospital more than
or someone that's administered medicine. I mean, it's still a bit of a patient.
Yep.
If
yeah, but
if some of them have medicine, I don't know.
It's a passive word, right? If you're a patient, you're receiving treatment instead of participating in treatment. And we talked about how it is important for people to feel that they are actually, if you're a client, think about going shopping for clothes, right? You are choosing the clothes that you want. You're like comparing things. You have agency. And I think it's important with any illness to have agency, right? If you go be treated for a heart condition, you might ask for a second opinion. You might not like your doctor and pick another doctor. You have agency on managing your illness. And I think that's important to convey when we're talking about our clients.
Yeah. And Rista, if I could just comment on your pointing out about the services that you provide. You try to make them individualized to the client based on their needs, their specific needs. And, I found that with my son, the different programs that he's been involved with I'm sorry, excuse me. Speaking of my son. Jonas, I'm just on a Zoom meeting. Can you call me back in about a half an hour? Okay. Thank you. Hi.
He's probably packing, so you have to.
He's probably packing. Yeah, no, I just find that to be very integral into the treatment. He's not at an entry level. He's been in recovery for 3 years now. And what I found after his last residential program, which, by the way, they call them guests there, which is
great.
yeah. But anyway, after that, I saw what really worked well with him. And it wasn't so much the focus on all of the daily therapeutic meetings with clinicians, because I think after a while there's less value in it. You know what I mean? For some. And in his case, he just wanted to get out and do something, you know, that he had to wake up and do in the morning, you know, and feel like he had respect from his peers and from the staff and feel worthy in his environment. And that's what I think, that was the first time in years that I saw him thriving. And even though he's done remarkably well at Continuum, and I'm ever, you know, be forever grateful, but I really felt like in his next thing would be more targeted to what, you know, he likes being in a suburban environment. He likes so I tried, you know, he likes being outdoors and working with his hands. So I'm trying to target that based on what I gleaned from his previous experiences. And, you know, I mean, maybe one day he'll be back, because I still think he's not ready to be fully launched into independence without more of a stability of his own under his belt and more confidence, more self-confidence. He has the self-awareness, but not the self-confidence.
But don't worry, we always take everyone back. And we
Thank you,
love
Rista.
once our client, always our client. So
Thank you.
you will always be welcome. And yes, that's part of targeting also their own needs, right? If you prefer a certain kind of program.
No, I think it's he that would do better. You know, for me, I would, you know, this was wonderful. I mean, this was like the best experience that he's had in a very long time. And I can't thank you enough. I hope everybody else has the same, you know, outcome, because I mean, I have my son back now. You know,
that's good to hear. And again, he's always welcome, but I hope he does wonderful in the next program.
Thank you, Rista.
Okay, well, we're gonna
wrap it up.
We started a little late, but we ran a little late. I'm gonna let you go. I would send this material, and for people that came late, please send me suggestions for our next round of educational you know, forums. Fran and everyone else that might not have a client no longer with us, these are open for the public in general. So if next,
thank you.
I can continue to send these out.
Yes, please.
And we'll continue to do this.
Also, Rista, I've been keeping a list of very helpful books that I've read on the subject, and I don't know if that's something that you you know, you kind of keep a list or want my input, or just to share with whoever's interested. You know,
I would love that.
Yeah.
I would, because I always send materials related to what we talked about, so people actually would like to explore that as well. I mean, like, did you see I put podcasts and things like that, so books will be cool too.
Okay.
All right.
Thank you so much.
Right.
Good luck
Have
to
a good
all.
night.
Thank you.
Everybody.
Thank you. Bye.